Good afternoon, everyone. Thank you very much for being here. Welcome to this public webinar on best practices, research gaps, and future priorities to support tapering patients on long-term opioid therapy. This webinar has been jointly organized by the National Academy of Medicine and the American Academy of Family Physicians. My name is Aisha Salman, and I am the Interim Director of the National Academy of Medicine's Action Collaborative on Countering the U.S. Opioid Epidemic, which I will describe further in just a minute. Before doing so, I would like to share a few acknowledgements. The American Academy of Family Physicians has been a valuable contributor to the work of the Action Collaborative. We have benefited greatly from their participation in the collaborative, which is represented by Dr. Chuck Rich, who you will hear from later today. And we're so pleased that we were able to work together to collaborate on this webinar. Today's free 90-minute webinar will provide insights on effective tools, strategies, and approaches to address opioid tapering. And we hope that you'll come away with a better understanding of the very practical aspects of this process. The webinar is being recorded, and the video along with the presenter slides will be available to you. We will post them on our respective websites after the event concludes today. Next slide, please. Today's webinar will last approximately 90 minutes and will follow the agenda that you see here on your screens. We'll begin with very brief introductory remarks provided by myself, as well as Dr. Helen Burstin, who will be moderating today's discussion. We will then hear from our panel of speakers, who will speak in the order listed here on your screens, and will each have about 10 minutes for each of their presentations. We will then move on to a moderated discussion with the panel before opening it up to questions from the webinar audience. And the webinar will conclude by 6 p.m. Eastern. Next slide, please. Questions and comments from the webinar audience are encouraged throughout the session today. All questions can be submitted at any point during the webinar, and we will do our best to get to as many of them as we can before the webinar concludes today. To submit your questions, please use the comment box on the bottom right of your screen. And as a reminder, since the webinar is being recorded, please keep in mind that any questions you submit may be read aloud and included in our webinar recording. Next slide, please. We also hope that you will join the conversation on social media. The NAM and AAFP Twitter handles are provided here on the slide, and we also encourage you to tweet over the course of the webinar by using the hashtags Opioid Collaborative and AAFP. Next slide, please. Now I'm going to spend just a couple of minutes providing a quick overview of our Action Collaborative on Countering the U.S. Opioid Epidemic. Next slide, please. Thank you. Recognizing the need for a cohesive and collaborative response to the nation's opioid epidemic, the National Academy of Medicine established the Action Collaborative on Countering the U.S. Opioid Epidemic in 2018 as a public-private partnership to foster greater coordination and collective action across the health system and beyond to address the opioid addiction crisis. The Action Collaborative uses a systems approach to convene and catalyze public, private, and nonprofit stakeholders to develop, curate, and disseminate multi-sector solutions designed to reduce opioid misuse and improve outcomes for individuals, families, and communities affected by the crisis. The Action Collaborative has 3 foundational goals that guide its work, and you can see our goals here listed on the slide. The first is to identify and raise the visibility of complex challenges, outstanding research gaps, and the needs of the opioid crisis that require a collective and multi-sectoral response. The second is to elevate and accelerate evidence-based, multi-sectoral, and interprofessional solutions to improve outcomes for those who are affected. And lastly, the Action Collaborative aims to catalyze action on shared priorities and solutions to overcome the crisis and improve outcomes for all. The Action Collaborative is led by a diverse steering committee, which is co-chaired by the NAM, the Aspen Institute, HHS, and HCA Healthcare. The Action Collaborative's work is organized around 4 core priority areas, which represent among the highest priority elements of the nation's response to the opioid crisis. These include strengthening health professional education and training around substance use disorders and pain management, improving pain management guidelines and evidence standards, accelerating, sustaining, and scaling prevention, treatment, and recovery services, and elevating pressing research, data, and metrics needs. Around these 4 focus areas, we have produced several policy and technical white papers, as well as webinars, public meetings, and a variety of dissemination activities. I would now like to introduce one of our Pain Management Working Group co-leads, Dr. Helen Burstin. Dr. Burstin is the Chief Executive Officer of the Council of Medical Specialty Societies, and as I mentioned, one of our co-leads for the Pain Management Guidelines and Evidence Standards Working Group. She's also our moderator for today. So Dr. Burstin, I will now hand it over to you to provide an overview of our working group and its focus areas, including tapering. Over to you.
Thank you so much, Aisha, and thank you so much for joining us today. We've heard there are more than 400 registrants, so clearly this is an area where you, like our working group, felt this was an incredibly important area where more work needed to be done. Can we have the next slide, please? I just want to quickly give you an overview of what our working group has been focused on, and it's co-chaired by Deb Horry, who's at CDC and directs their injury center. And we've wanted to really focus on where we could strengthen critical aspects around pain management, including guidelines, tapering guidance, multidisciplinary pain approaches, and really thinking about how pain guidelines get implemented into practice. So we've identified 4 areas, and these really came from our working group, as well as some listening sessions that we've been doing with the broader community, including patients. We want to understand where the evidence and the related best practices are for when opioids are indicated, when they could potentially be tapered, as we'll talk about today, or even discontinued. We want to highlight where there are evidence-based approaches to integrative pain management, including strategies to support the broader implementation of these multimodal approaches. And then finally, really thinking about the fact that we've heard a fair amount about how oftentimes the guidelines that have been out there have been misinterpreted. We also want to be cautious about supporting the implementation of pain guidelines into practice while monitoring for both intended and unintended consequences. I'll mention we're now looking towards focusing on the second phase of work for the Opioid Collaborative and a couple of areas that are rising to the top for our next phase of work. And we'd welcome your thoughts about this during the Q&A, are issues around stigma, equity, and the role of telemedicine and virtual health in the pain management arena. So specifically on the chronic pain and tapering area, we have really focused on looking at the management of chronic pain as a public health issue. We've certainly seen that the prescriptions for opioids for pain have declined, but there continues to be significant impacts on both mortality and morbidity. Opioid tapering is an approach to support the safety and well-being of some patients. And I think you'll hear today from our panelists that this is really a shared decision-making imperative here, that it is really for some patients. And we recognize that tapering is complex. And it has to be a collaborative decision. So today what we're going to do with our great panel is really explore these key considerations, best practices, tools, and resources for effective tapering. I think you'll really find it just a great set of speakers, and it should launch a lot of good Q&A to follow. So next slide, please. Let me just briefly introduce each of our speakers, and then I'll call on them one at a time. First, I want to introduce Chuck Rich, also known as Robert, who is a member of our pain management working group and the lead author of our tapering paper that was produced through the National Academy of Medicine. We're delighted to have Chuck here with us today. He has a long-standing background as a family physician himself, as well as his work in regional networks in North Carolina, really thinking about how to teach and help people understand how to use opioids. Secondly, delighted to have Dr. Ada Stewart, the relatively new, I think, president of the American Academy of Family Physicians, joining us today. I was joking with her in the pre-call that she's the only colonel on our group, former colonel. She has a long history as well in family medicine and public health, dating all the way back to her days as a National Health Service Corps recipient when she started her time in South Carolina, and remarkably hasn't left. So that's true commitment. And she'll talk about some of the work she's been doing as a practicing family physician in her community, as well as the national issues. Next, Liz Bentley, and we're delighted to have a pharmacist among us because we recognize this area in particular really has to be a team-based approach with the clinician, the pharmacist, and the patient. And Liz is the director of clinical pharmacy services for Kaiser Permanente Northwest and has played a pretty significant role overall at Kaiser in thinking about their controlled substances work. And last but not least, David Ogurick, who is an associate professor at Temple, also a family medicine. David also has a long history of focusing on this area, including being a provider of medication-assisted treatment, as well as working within the Philadelphia community around overdoses. So really great to have this blend of people representing urban areas, rural areas, and a whole set of different perspectives and disciplines. So with that, I am delighted to turn the stage over to Chuck, who will walk you through the work we have done so far as part of the Tapering initiative. Chuck, over to you.
And good afternoon, everyone. It's a pleasure to see everyone. Before I actually start talking about our paper, I've got to recognize the individuals that helped contribute to the production of this paper. To that, I would like to recognize Roger Chow from the Oregon Health and Science University, Ed Mariano from the American Society of Anesthesiologists, Anna Dopp, PharmD from the American Society of Health System Pharmacists, Rebecca Sellinger from our own NEAM, and our esteemed moderator today, Helen Burstin from the Council of Medical Specialty Societies. I'd also like to recognize the other members of our work group who contributed, but were not direct authors. Next slide. Again, today's paper and its title and everything, again, I'll be talking briefly about the key points of today's paper and some priorities and research opportunities for the future. Again, next slide. Without reiterating the background of where we are today in terms of opioids and pain management, I think it's suffice to say that most guidelines that have been developed over the past several years focus a lot on the newer patient, leaving out what we've termed the legacy patient or the patient who's already on chronic opioid therapy, often combined at times at high doses or combined with benzodiazepines and hypnotics. So unfortunately, we're left sometimes as providers and patients to determine what to do in reference to their therapy, whether you discontinue, whether you taper, and what you do with combination therapies. In looking at the problem, the work groups decide we're going to take an approach in terms of a risk reduction as the background and basis for the paper that we developed. It's interesting, at the same time that we were finishing up the work on the paper again, the Health and Human Services published their tapering guideline, which was just released in 2019 and was subsequently part of the background material that we continue to use in the development of this paper. Next slide. Going over a couple of the key points that we have today. First, as you can imagine, there are some benefits to tapering long-term opioid therapy, including such things as improved pain and functioning, believe it or not, lessen risk of accidental overdose and death, lessen side effects, lessen impairment of, again, process in individuals such as individuals with lung disease and liver disease, and certainly an improved risk profiles in some of your high-risk patients such as your youth and pregnant women. Similarly, we do recognize there are some possible risks associated with tapering, including, again, worsened pain, unmasked opioid dependency, unmasked behavioral health conditions in those individuals not previously diagnosed, and as you can imagine, certainly, again, precipitated withdrawal syndrome in those patients who undergo rapid tapering or rapid abrupt discontinuation. We also acknowledge, as another key point for the paper, that there are a significant proportion of patients on long-term opioid therapy with chronic pain who may have underlying behavioral health disorders, including depression, anxiety, substance abuse disorders, which, while if not recognized, could contribute to accidental overdose and death. And as such, lack of treatment of those same disorders may impair your efforts to taper and or discontinue long-acting opioid therapy. Next slide. Similarly, we do acknowledge there are patient concerns about tapering, and these are not to be diminished, but we do acknowledge there are concerns from our patients, such as concerns about worsened pain and function, the development of withdrawal symptoms, and possible stigma associated with the withdrawal. These are very real concerns on the part of our patients who have been on long-acting opioid therapy, sometimes for many years. And we do recognize, again, that abrupt discontinuation certainly can be very, very, very much a concern for our patients. As Helen has already mentioned, we again have posited that opioid tapering should be initiated via shared decision-making process, addressing those same concerns and working with our patients to obtain patient buy-in. We also acknowledge that there is little evidence sometimes to guide the speed of tapering, how, again, to taper our patients who are on combinations of opioids and other high-risk medications, and how to determine the endpoint of successful taper, which in some patients is months to years and may not involve the complete discontinuation of opioids. It may be, again, a tapering to the lowest effective doses. And how do you determine that? Next slide. We also, as one of the key points of the paper, do point out, we do feel that there is substantial need to improve the use of adjunctive therapies, both pharmacologic and non-pharmacologic, before and during the tapering process to manage, again, help manage chronic pain, underlying behavioral health disorder, and to ensure improved success of that tapering process without addressing, again, some of those additional concerns with adjunctive therapies, which we'll mention briefly. Again, the success goes downward in terms of a successful tapering. As I've already mentioned, tapering should be guided by ongoing assessments of pain, function, and may benefit from the use of assessment tools to help guide that process. Similarly, some of us who have been working with our legacy patients have found that use of a tapering agreement can help facilitate that process by improving, again, communication between the patient and the provider, clarifying, again, how that taper is to be accomplished, and clarifying how we will deal with some of the problems which may be encountered during the tapering process. Finally, again, we also, again, at one of our points, we have said that tapering should be slow to pause, but should not be reversed during this process without maximizing the adjunctive therapies to help manage, again, pain, as well as underlying behavioral health issues. This reversal should be guided, again, by, if it occurs, it must be guided by a reassessment of risks versus benefits, again, via a shared decision-making process. In particular, in the primary care setting, may be an ideal time, if a reversal is being considered, to obtain additional consultation, again, particularly for, again, with pain management, with behavioral health, and other specialties. Next slide. The second portion of my brief talk talks about some of the research gaps, which we highlight as part of the paper, which I'll go through briefly. The first recommendation is to identify, as we've already said, the appropriate tapering speed, including those patients, distinct patient populations, beginning with those patients who may be on high dose opioid therapy, which we define as greater than 90 MMEs equivalents, patients with suspected opioid use disorders, patients with coexisting behavioral health disorders. As I've noted, there is little evidence, particularly long duration evidence, to help guide decision-making about the speed of tapering in these patient populations and even in individual patients. Again, most of our current recommendations that are in use now are primarily based upon consensus recommendations from experience with, in general, the rule of thumb: the longer that a patient has been on long-acting opioid therapy, the longer the taper. Next slide. Adjunctive therapies. As I've mentioned, again, our recommendation, determine the optimal non-opioid pharmacologic and non-pharmacologic treatments to help manage pain for individual patients, beginning with the use of cognitive behavioral therapy and tapering, use of antidepressants in tapering, specifically in those patients with and without behavioral health disorders, and again, the increasingly complex issue of the use of gabapentinoids in tapering. Research has already alluded to there is a place for pharmacologic and non-pharmacologic adjuncts for managing chronic pain, but there's little evidence so far really to help guide their usage in tapering and also their sequence in tapering. We feel that, again, additional research is needed for the use of non-pharmacologic treatments, including which treatments are beneficial for tapering, how they should be used, when they should be used. One of the benefits we do believe that with additional evidence for these therapies, this may be a pathway to help provide additional insurance coverage for those therapies, which often or may not be covered for the specific act of tapering. Next slide. Okay, next, another research gap. The question of interdisciplinary teams, and you'll hear more about one interdisciplinary team in later discussion as one from other presenters. A recommendation, again, determine the efficacy around the use of interdisciplinary teams in tapering. There is some basic evidence which has indicated that there is some utility for the use of an interdisciplinary team, but those studies have primarily been short-term and with small pools of patients. So certainly, again, longer studies are needed with the larger patient pools. Additionally, research is needed to help guide which personnel should participate as part of a tapering team, what kind of integrative care is beneficial, and when that care should be employed at the beginning, the end, et cetera, as a part of the tapering process. And again, as I've alluded to in the previous slide, if we've got evidence for the beneficial usage of integrative care, that should also help to expand insurance coverage for those services. Next slide. Interesting topic, research gap. Determine how to best employ opioid agonists in the use of opioid use disorder and chronic pain, and how the use of buprenorphine and methadone may be beneficial in tapering patients with persistent opioid dependence. We know that in patients with coexisting substance use disorder, these medications are used, but there's additionally a use now that we're seeing where, again, these therapies are used to help transition patients off of long-acting opioid therapy for the purpose specifically of tapering. Therefore, we need additional evidence to, again, consider how that should be used, particularly in those individuals that have never been diagnosed as having an opioid use disorder. Are these therapies beneficial? At what point in a transition process could these medications be beneficial? What kind of speed would subsequently then be applied to these therapies if they're used, as well as looking at the complications, those re-escalations, and other endpoints compared to the usual therapies. Again, and if they're found, again, it's interesting, again, for a practical application, again, if we do find that use of these therapies are beneficial in tapering, does a provider have to be trained via the waiver training to use these adjunctive therapies, or could they use without waiver training? Next slide. Again, we've identified polypharmacy patients as a particular area where, again, there will be need for much more further research. Again, as I've noted, there are a lot of patients, again, on pre-existing long-acting therapy who are on polypharmacy, including benzodiazepines, hypnotics, muscle laxatives, and other sedating medications. And as you maybe imagine, all these medications together increase the risk of adverse events. Well, what research is there to help guide the provider in terms of how to handle these polypharmacy patients, in terms of which medication do you taper first, which ones do you taper concurrently, which category of medication may need to be tapered prior to tapering the opioid therapy, the speed at which, again, you would taper a particular other medication, and again, just best practices in general. Again, another big category where, again, there are a significant number of patients that, again, are on polypharmacy, and much more guidance is needed in terms of how a provider is to deal with this category of patient. Next slide. Behavioral health issues, I've already mentioned again that we have identified that there is a significant number of, again, patients on long-acting therapy who may have behavioral health issues. Research is needed how to better handle and manage behavioral health disorders in the chronic pain patient and the opioid tapering patient. Which therapies are beneficial to tapering? When do you start those therapies? How long do you continue those therapies? And what's their role in maintenance after a patient has been successfully tapered? We also need to know, again, some measures in terms of, again, how tapering may be ultimately positively impacted by behavioral therapies. And in the end, which behavioral therapies would produce the most benefit for tapering. Next slide. And finally, final research gap which we've identified, as I've mentioned already, is again, looking at the evidence, again, the risks versus benefits of opioid tapering. We acknowledge again that there is some research which again does indicate there is a benefit to opioid tapering, but the evidence for the use for the evidence for the risk of tapering is limited even more so, and primarily consists of anecdotal reports. In particular, again, research is needed into higher quality, longer duration, larger patient panels to determine the risks versus benefits to help, again, providers and patients make a decision about how to taper the long-term opioid therapy. So with that, I'll turn it back over to Helen.
Thank you so much, Chuck. That was great and really helpful overview. We've already got a lot of questions in the chat box. Feel free to keep putting them in. We're not going to stop between panelists, but we will come back to all your questions, or as many as we can get to at the end of it. So I'm now delighted to turn the stage over to Dr. Stewart.
Thank you so much, Dr. Burstin. So it's really important that I just kind of give a brief overview of who the American Academy of Family Physicians is. It's a professional organization that represents over 136,700 family physicians, which include residents and students in the United States. It also represents 55 chapters, state and territories, and also the uniformed services. And family physicians provide comprehensive, continuous primary health care to patients regardless of gender, age, or issue. Next slide. And the vision of the AAFP is to transform healthcare to achieve optimum health for everyone. And our mission is to improve the health of patients, families, and communities by serving the needs of members with professionalism and creativity. Next slide. So as we talk about the primary goals for pain management, and Dr. Rich talked about patient improvement and maintaining function, you know, we understand that chronic non-cancer pain management is a challenge. It's a challenge between achieving pain management in addition to the significant spike that we have had in opioid use that has led to misuse, abuse, and dependence. And that creates a difficult balance for us all as we talk about the opioid epidemic. But the AAFP now has a lot of resources, which includes a chronic pain management toolkit that helps us to use the important work that we find before us through patient engagement and shared decision-making to address this very issue. For family physicians, we focus on patient engagement and shared decision-making. We look at conversations that we have within that exam room, talking about pain and treatment goals. We have the opportunity through our pain management tools to look at the standardized evaluation and treatment of patients with chronic pain and to identify and mitigate risks that may occur. Next slide. And as we looking at considering even tapering an individual, we have to look at the tools that we have before us and recognizing that the objective of opioid tapering is to reduce significant withdrawal symptoms while reducing or discontinuing opioid use in those individuals who we find that this is a consideration. And why are we thinking about even tapering individuals who are on long-term opioid use? As Dr. Rich said, some patients request that. We may not see the lack of improvement as we go along on long-term opioid use. Patients may have some non-adherent to treatment plans. We may see a risk of misuse or abuse, or we may see serious adverse events. In that discussion, though, of tapering sometimes can cause extreme stress, anxiety, no matter what the reason, whether the patient requested or we find that there are some significant adverse effects of long-term opioid use in this particular patient, we have to recognize that this may bring some angst as we address it with our patients. So we have to be ready and willing to talk to our patients about this. Next slide. It is great that the AAFP has a number of tools that are available, and you can find this again on our website. It has a brief pain inventory that we can look at, looking at the evaluation of pain within that particular individual. It also includes a list of functional goals. What is the function that patients are trying to achieve? Are they able to work? Are they able to do their activities of daily living? Is pain preventing these things from happening? And our toolkit also has what we can consider an action plan of how best to achieve these the tapering goals of that particular individual. And the biggest thing for family physicians, as we have limited time within our confines of an office visit, is to recognize that this takes time. We have to set aside time to talk with our patients during this very sensitive topic when we are discussing tapering, and be ready to be empathetic with our patients. Recognizing that, again, there is the potential to have some anxiety, some just stressors, just thinking about this very issue. And so we have to be empathetic, talk to our patients, have that shared decision-making as we approach this particular subject. I really love using motivational interviewing. This is a way that we can make sure that our patients know that we understand their concerns, that we're there listening to them and ready to meet them where they are, and recognizing that each patient is an individual patient, and each one will be different. Next slide, please. There's no evidence to really have one tapering strategy over another. Again, as I mentioned, it's individualized. We do have a tapering resource within the AAFP. Also, we have a conversion table that you can look at to see the equivalent dosages as you start to taper that individual from one opioid to another and taper the dosages. So we have guidance to help our physicians to go through this process, to make sure that we're doing what we can to help our patients deal with this, and that we're there for them as we go through our shared decision-making with each and every patient. It is important that we take it slow, that we make sure that every step of the way that we're there, and we encourage, we're there for encouragement, there for support, and that we monitor for signs of withdrawal. Not everyone goes through withdrawal. There's different types of withdrawal. There's the physical withdrawal, which usually we see within 5 or 10 days, and then there's psychological withdrawal, which could last a lot longer. And we have to be there for our patients. We have a number, again, of resources for tapering, and this is really a guideline. It's something that you can use to guide you through the tapering process for your particular patient. Next slide. It is important too that, we look at what is our endpoint. Is the tapering considered complete when we have one completely off of opioids, or is it just a lower dose? recognize that each patient, again, is different. Some may be just a decrease in dosage, or some may be a complete cessation of the opioid. Each patient is different, and we are there as family physicians to continue to monitor our patients throughout what we find is a patient-centered and patient-engaged evaluation. We have to look at, paying attention to how we are tapering and looking at the dosages that we are taking our patients through. Next slide, please. Again, this is a shared decision-making, and we have to have patient buy-in. And how do we do that? We are supportive. We have to make sure that this is a shared decision-making process. Patients should be aware and ready and agreeable for the rationale for the taper. We have protocols that will be involved, but again, we have to know and be able to explain to each patient what our expectations are for each stage of the tapering. And we can do this through our resources that help us with guiding us through all of this. Again, motivational interviewing is really important, and it's very effective to get that patient buy-in, recognizing readiness of that patient. How are we going to increase their desire to taper? And how are we going to be able to address the concerns that they have as we approach this subject? Next slide. One thing that is really important as family physicians, we have the opportunity to engage with families and with their caregivers. Again, as we look at each patient being different, some patients really need that support, and having family members and having caregivers involved in this process, it gives them a supportive environment, and it helps them to go through this very difficult sometimes process. Making sure again that we recognize that this is something that we need to discuss with our patients and see if it's something that they really want to have as part of their process, if their family members are willing and there to be part of their support system as we go through this shared decision making. Next slide. It's important that as family physicians, we have to recognize that, again, certain situations are more difficult. Individuals who are on high dose opioids or multiple opioids can create a challenge. And so we encourage family physicians to obtain a waiver and incorporate medication-assisted treatment into their practice. This is a way that we can address individuals who may be more challenging as we consider tapering, or we consider other options as we move forward. We also have to make sure that we have regular monitoring and evaluation of the process of patients throughout this process during the taper, and be ready and willing to respond, either by temporarily maintaining them at one tapering dose, or kind of stepping back and restarting, or using our team approach, incorporating our behavioral health individuals, making sure that we reassess that patient for opioid use disorder. Next slide. Thank you.
Thank you so much, Dr. Stewart. That was wonderful. So we're delighted now to turn the stage over to Liz Bentley, who will provide the really important perspective of a pharmacist on the team around these questions of tapering. Liz, over to you.
Thank you so much, Dr. Burstin. It's really an honor to be here today to talk about the role pharmacists can play in this process. And we'll go to the next slide. And one more slide. I'd like to start by providing some background information about Kaiser Permanente to help frame our discussion for today. Kaiser Permanente is a fully integrated healthcare delivery system, and we provide healthcare and insurance to 12.4 million members in 8 regions. that covers California, Oregon, Washington, Hawaii, Colorado, Georgia, and the Mid-Atlantic states of Maryland, Washington, D.C., and Virginia. We have 39 hospitals and 719 medical offices. And as an organization, we started to see growing use of opioids for pain management in the late 2000s, and we're quick to pick up on the potentially adverse consequences of unrestrained opioid use prior to its being officially labeled as an epidemic. And our approach has been successful due to leadership commitment, collaboration across disciplines, population health-based tools, providing extensive clinician and patient education, and a focus on the highest quality of care for each and every patient. Our opioid stewardship programs focus on limiting opioid prescriptions overall. However, that approach is not enough for a successful process that keeps the patient at the center. And the true north is really to provide effective pain management alternatives and reserve opioids for when they're clinically indicated for the patient. In addition, we work in partnership with patients to reduce or discontinue use of opioids, increase access to naloxone, and provide pharmacy support for tapering and monitoring in partnership with prescribers and the entire care team. On the next slide, I'm going to focus in more on the pharmacist's role in pain management. So if you could just advance there. And this includes opioid tapering. And here's where I'd really like to highlight the work of the American Society of Health System Pharmacists, or ASHP, Opioid Task Force. And this was an interdisciplinary team that met in October 2019 to develop recommendations on how to address the opioid epidemic, with a focus on the role that pharmacists can play in this area. And I would encourage you to read the full report for more information on pharmacist roles and opioid stewardship to consider which recommendations you might be able to leverage for your hospital or healthcare system. Pharmacist roles may include providing services for the management of pain and opioid use disorder, screening for and providing preventative measures for opioid misuse, participating in evidence-based evaluation of treatment options, for example, formulary management, recommending multimodal pain management treatments, which include both medication and non-medication options, and participating in pain management and opioid stewardship programs. Now, I'd be remiss not to mention that a few short months after the task force met, we did experience an event that changed our world at an accelerated pace, and that's COVID-19. And it would be an understatement to say that this pandemic has had a monumental impact on how we provide healthcare in this country. And telehealth, including video visits, are being leveraged to their full potential. And this has been an improvement in access to care and has improved communication with providers for some, while others have really experienced issues with technology that have limited their full participation in virtual groups. And on the next slide, I'll discuss a little bit more about how we leverage telehealth to improve patient outcomes. So at Kaiser Permanente, our opioid stewardship programs are founded on the core principles of safe and patient-centered pain management. And there are exceptional teams in all of our regions that support this work. And I'm going to speak more specifically about our teams in Oregon and Washington, or what we call Kaiser Permanente Northwest, because that's where I'm based. And one of our existing options that leverages telehealth is our pharmacist-led opioid tapering program. In this model, the primary care physician or other provider first completes training in what the team can offer to support patients through a taper. And that includes actively involving each patient in the decision-making process. And once that training is complete, the prescriber can refer patients. And before the patient is referred for active management, the prescriber has a conversation with the patient on the goals of therapy and why tapering may be a good option from both a safety and a quality perspective. And during that conversation, the provider may decide tapering isn't the right approach, that they would like to complete the taper themselves, or that they would like to refer the patient to the team to manage. And once the patient is referred to the program, a pharmacist on the team completes a review to determine whether the patient would most benefit from full tapering support, a consultation, or a referral to another service, such as pain clinic, addiction medicine, or mental health. And in addition to the pharmacist, the team includes a physician mentor and a social worker. And the collaboration between this tight-knit interdisciplinary group and the continued communication with the prescriber throughout this process are strong components of the program's success. On the next slide, I'd like to review some of the amazing results from our program. Year after year, we've been able to sustain more than 50% reduction in what we call the baseline daily average morphine milligram equivalents for our patients. And you'll notice that the average patient doses were higher at the start of the program in 2010 and through 2014. And that's because this represented the height of the opioid epidemic and efforts in the organization. And the community also promoted an ongoing downward trend in opioid prescribing. What I think is really, truly incredible is that those results are sustained for 3 to 6 months and even beyond the time of discharge. And the reason for that is because of the coaching and pain management techniques our physicians, social workers, and pharmacists provide to these patients throughout the course of the taper. It goes beyond just reducing doses or discontinuing use because our team works to address the root of the problem as opposed to relying on opioids or even on medication-only options. And the next slide, please. And the true proof point of the impact of our program can be heard in the testimonials from our patients. And over, we've heard how this patient-centered approach helps people get their lives back. And according to our survey results, most patients rate their pain as either unchanged or improved after the tapering process is complete, which is really pretty remarkable considering the high doses of opioids some patients start on. And these quotes really represent just some of the journeys our patients have been on with the healthcare team. And as one of our patients noted, I wouldn't have been able to go through the process at all without that extra help they provided, just the support, just to know they care, and they really do care. Another shared effort I wanted to highlight that we have across the organization, if you could go to the next slide, is really increasing access to naloxone and helping to reduce the stigma or other barriers associated with requesting the drug. And specifically in the state of Oregon, a law was passed to allow pharmacists to independently prescribe medications on the state-approved formulary. And we provided training to our pharmacists and adopted that practice shortly thereafter with no appointment required. And as a testament to this increased access, the number of patients with a prescription for naloxone increased 64% from 2017 to 2019, and we've seen that continue to increase into 2020. Another way that pharmacists can help with monitoring patients on opioid therapy is by working in partnership with the prescriber and the rest of the care team to monitor several other components of therapy. And on the next slide, I wanted to end this section by highlighting the essential role of the social worker on the team. And she's really been instrumental to the success of the group since it started 10 years ago. And as she really likes to say, our pharmacists are honorary social workers, and she feels like an honorary pharmacist. This is very true. She typically has the first outreach to patients in our telephonic program, as I covered above. And in her experience, to quote, people are petrified, they don't want to taper, they're angry about it, they're scared about it, and I'm the first person to reach out. What I'm doing for a 60-minute telephone call is I'm building trust and confidence and rapport in this buy-in so that when the pharmacist comes along behind me and calls the patient, there's a second call, and then the patient is now willing to try to taper. So just reinforcing, really spending the time with each and every patient to make sure that we're coming up with a customized approach that everybody buys into. And on the last slide, while we do have set roles for the social worker on our tapering team, all of the team members may flex to cover needs based on patient-specific situations. The core roles for the social worker are to introduce the patient to the tapering program, provide counseling to set expectations, obtain information about pain location, level of pain and perceptions, review non-pharmacologic strategies, screen patients using the PHQ-9, follow up with the physician or additional mental health resources as appropriate, and triage patient needs throughout the process. So thank you very much for giving me the time to talk about the pharmacist's role, and very much looking forward to hearing more about behavioral health integration from our next presenter.
Thank you so much, Liz. So next we'll have Dr. David O'Gurk give his perspective, as well as bringing in some of those elements around behavioral health. And I'll tell you, David, as you start, a lot of the questions are about behavioral health, and in particular, access to behavioral health, access to alternative therapies. And I know you're going to talk about some of that. So thank you.
Thanks, Dr. Burstin, and thanks to everyone for joining in. I'm very delighted to be here and be able to talk about this. Can we move to the next slide, please? So as we approach behavioral health integration, I want to set the stage that we're really going to be talking kind of very broadly in terms of an overview, just given time constraints. We certainly won't be able to address all the intricacies of the process of integration, but hopefully with your questions that you've already asked, as well as the follow-up questions during the discussion time, we could really address some of the specifics. Can we move to the next slide? So I think as we think about this, we need to recognize that the need for behavioral health integration into these treatment aspects isn't unique to the tapering process, as we're talking about a tapering process here. It really overlaps with the need for behavioral health integration into both prevention, potentially, if we have that possibility, to prevent the conversion of acute pain to chronic pain, as well as throughout the process of the treatment of chronic pain in general, whether we're using long-term opioids or whether we're using other pharmacologic or other non-pharmacologic interventions. This isn't unique or different. We also need to recognize that individuals who experience chronic pain often have had significant trauma history, some with a confirmed, some with an unconfirmed diagnosis of something like post-traumatic stress disorder, which certainly impacts their treatment and can certainly affect sort of their reaction to some of the things that we may typically think of should be effective. And if we're not being comprehensive in the way we approach this and have the elements of behavioral health involved, either directly within the practice setting that treatment's occurring in, or through collaboratives or networks with other partners, we might be really missing a key piece of the treatment. And the trauma that we talk about that can happen here, it can be at the individual level. We talk about things like adverse childhood experiences, but also adult traumas and things that happen, as well as things that are happening at the community level, or even intergenerational trauma that affects really the overall health of individuals as well as the population. So these things aren't perhaps unique to chronic pain, but they're certainly things that impact overall health for individuals. But if we're treating chronic pain in a comprehensive manner, our evaluation and management throughout certainly would involve addressing these components and making sure that we realize sort of the link. And you can see sort of from the diagram in the upper right-hand corner of the slide, oftentimes what I'll talk about with patients is sort of that link when someone experiences pain and the pain gets worse, and then the associated anxiety or depression or other comorbid symptoms that may come about as a result of this, and how that could actually worsen the pain, which then results in this cycle. And we could potentially be missing the ball if we're just focusing on the physical elements and the function elements, and we're not really addressing those behavioral needs. Next slide. So really, as we think about our approach, both preceding, during, or after the tapering process, if we're specifically focusing on the tapering process here, we must address this in a trauma-sensitive way. We know the effects of trauma and things like adverse childhood experiences on different elements. Chronic pain certainly affects the brain in different ways. It affects the body in certain ways. And again, some comorbid behavioral health, either diagnoses or symptoms that people may be experiencing, can affect people in different ways. So as we approach this process and we talk about shared decision-making, the paper specifically points out for people that it's working well for, we're not suggesting that all people must taper. For people that it's working well for, the shared decision-making is around other situations where the person's maybe prepared to do that, or whether there's things that may raise as part of our concern because of some behaviors. But as we look about some of these behaviors, some of them are things that may trigger a physician or a provider or a pharmacist or someone as part of the treatment team to say, I have some concerns here. But we need to recognize that some of those concerns may be coming about not because the treatment that we're providing isn't working, but because we're not addressing some of the trauma elements that may be affecting things, or some of the behavioral health elements that may be affecting things in a certain way that result occasionally in behaviors that perhaps society or medical treatment seems and deems as maladaptive, but really are protective in the element for an individual, particularly those who have experienced trauma or stigma in certain ways, and as a result sort of are reacting in a way to try to protect themselves. But at a very basic level, this tapering continuum, we really must foster a trauma-sensitive and trauma-informed culture that ensures patients are treated with dignity and respect throughout the process. So as we're talking about shared decision-making and involving the patient, we're making sure that we're not jumping to conclusions based on things that are outside of our element or we didn't explore further. Next slide, please. So really, as we look at the integration, there's certainly a number of facilitators as well as barriers to this process. Over time, we know that there's been increasing recognition at the system level as well as the policy level for the value of behavioral health integration. Some of the facilitators in and around this that we need to recognize is there's really no one-size-fits-all approach. Excuse me. So there are different models for integration that can look at where everything's certainly under one roof and integrated into a practice setting, or you're using community partners, or you have a medical neighborhood in and around this, either directly within your system or through other community benefit organizations or other partners or outside entities, including leveraging telehealth. And we'll talk about that a little bit later, as was already mentioned. But resources certainly also exist as a barrier and a limitation, and payment structures that support the needed staffing and resources within practices to be able to provide integration that's on site, or even resource availability, often in rural settings, remain a significant challenge where perhaps some of these things aren't available, or they're not available because the patient can't access them because of distance, because of transportation issues, and many other reasons. So it's important to note that some of the care that we think about, and perhaps, you know, the mindset is referral to behavioral health involves sort of a psychiatrist or a psychologist or a community counseling agency. Some of it certainly can be delivered within the office, and some of the training of a primary care physician or a healthcare provider can deliver some of the mini CBT or the support directly in the practice. We could also leverage our staff. There may be champions within the practice themselves who are peer specialists or peer advisors that could really help in this process and provide support to patients. And there's certainly a huge role for certainly having that peer element of things where someone who has been there and experienced that can help someone walk through the process together. While time constraints, as Dr. Stewart mentioned earlier, are certainly an issue, you know, again, primary care physicians are equipped with the knowledge to lay the foundation for behavioral health treatments in this process. And certainly for more complex circumstances where additional services are needed, we need to think about the opportunity of utilizing telehealth, which has opened the capacity to access even in limited resource areas. But as already was alluded to, telehealth also sort of brings up and highlights some of the inequities, sort of if we rely completely on telehealth, certain populations, people experiencing homelessness, people that may not have access to telephones, people that may not have access to good cell phone service or access to video capabilities and those sorts of things, don't have the opportunities that other people would with those settings. So we certainly can't hang our hat completely on the ability for telehealth to deliver this type of care. As you see within the barriers, one of the big things that's throughout, both at the policy, the institution community level, and the practice level, is stigma. Next slide. So stigma is huge here. And it really remains a significant barrier within systems. People are consistently dealing with frustrations within the systems, perhaps from their physician, from their provider, from accessing medications, accessing services, feeling like they're being forced to taper, not understanding why decisions are happening. And we need to address this. This is certainly part of the conversation that needs to occur, and why shared decision-making is essential, and why sort of forced tapering isn't sort of what we're trying to promote or what we're trying to access, what we're trying to sort of propose here. You know, as we approach addressing behavioral health challenges in this component of the care, We also need to be careful that it doesn't come across that we're just referring somebody to a psychologist or we're referring someone to a psychiatrist with the notion that maybe we may be selling a message that, oh, this, may only be in your head, or you're not really feeling this, or we don't understand why you're still having this pain, sort of all your studies are normal, or these sorts of things. You need to be very careful because those things are said to patients, or patients hear them in certain ways. And that's maybe not what the person meant, but that's certainly what the individual heard. And we need to be very careful around the language that we use for people who experience chronic pain, because that's a first step in certainly addressing the stigma, that we're not using stigmatizing language, that we're not marginalizing even further in our messaging. The 5 principles of trauma-informed care can certainly be utilized in these care conversations and connections with patients, really to foster an environment that breaks down stigma and is a much more supportive culture. Next slide. So as we look at sort of this bigger picture and sort of the bigger spectrum here, certainly we see, within the tapering care continuum, there's certainly elements that are involved here that were touched on by my colleagues earlier. Certainly there are elements, again, within practices for behavioral health integration. Sometimes it's just important to look internally and see what resources you have. Doing things like implicit bias trainings, acknowledging sort of our own biases around opioids or chronic pain, or things that we may jump to conclusions to, and not acknowledging that people have been hurt and have experienced trauma and maybe coping with other, again, comorbid, either diagnosed or undiagnosed behavioral health diagnoses are critical. Certainly bridging the conversation about individuals who have developed a substance use disorder, or who have a substance use disorder that perhaps was missed. That's certainly a conversation that needs to be handled appropriately, but not jump to conclusions as well, and sort of making clear distinctions that while things like dependence and tolerance are components of someone developing a substance use disorder, those alone do not define someone having a substance use disorder. So making it clear that we're making appropriate diagnoses and appropriate distinctions between those things, and having discussions around what those things may or may not mean, and whether they are or are not harmful or helpful to the patient, is a critical thing as part of this process that we need to be open. When those cases come up, as was mentioned by Dr. Stewart and Dr. Rich, certainly the notion of having availability of office-based opioid treatment and implementing some of the pharmacologic treatments for things like opioid use disorder are certainly available within practices, and having the availability to do that right on site or with your healthcare provider or your primary care physician that you've been seeing over time is certainly a critical thing, and having access to that is important. Next slide. So these really are the key takeaways that I hope to have conveyed sort of over the last couple of minutes, that really these behavioral health supports and this integration, this is essential across the care continuum. While we're specifically looking at the tapering process, we are not, this isn't something unique to that. It really needs to be both across the preventative and the treatment and the long-term management goals for the individual. Certainly, different integration models exist out there, and you need to find what could work for you or what will work for you. There certainly needs to be increased attention on payment and policy changes that certainly foster improved access to behavioral health mechanisms and supports for individuals, and not forcing people to do sort of very specific counseling, or you need to attend this specific group or this specific thing, but what's available to them, and they have a menu of options, and that they get to choose what might work for them and work for, within their time constraints and their life cycle. With this approach, research doesn't recommend one single approach, and that's why it's presenting a menu of options, and again, meeting the patient where they're at with what they would be interested or willing to do as part of this process. And that's not different from behavioral health integration into other disease processes or just behavioral health treatments in general. And I think this really opens up, the opportunities really to develop a medical neighborhood and develop more collaborations with partners, both utilizing telehealth as well as in-person strategies for individuals, knowing that as part of this, we need to be addressing the inequities that exist because of access to those, as well as addressing social determinants and the psychosocial factors that affect health. That was on the previous slide, looking at things like housing, transportation, education, and those core essential elements that are important for health. Thank you.
Great, thank you so much, David. I'll invite the other panelists to join us back in with their pictures, and we'll get into a discussion. We've had, wow, a lot of comments in the Q&A box, which is wonderful. Great to see that engagement. I will say one of the most dominant themes of those questions are largely from patients asking, the basic question is there evidence that tapering necessarily, particularly for patients on long-term opiate therapy, is there really evidence saying that tapering them leads to better function or better outcomes? Let's just start there. Anybody? Chuck, do you want to start and maybe then ask others?
Yes, thank you, Helen. There is a small study which does suggest that long-term, that successful tapering has led to improvement in that patient population that was studied in terms of their pain scores and overall functioning. The study, I can't remember the exact details of the study, and I don't remember exactly how long the study actually was carried on for, but there was, again, a study which did suggest there was some improvement. Certainly, again, that is one of the areas, again, we have called for additional research into the benefits of studying, and I really acknowledge there's much more work to be done, but there is some small studies that does suggest there is some benefit.
Okay. Anyone else want to weigh in on that question? I'll just point out as well in the chat, somebody also pointed to a very recent VA rapid synthesis review in the Journal of General Internal Medicine that looked specifically at patients on long-term opiate therapy for chronic pain, in which they did actually not find, they found the net benefits of harms of dose reduction was unclear. So I think calling that research question is really important. Were you going to jump in, Liz? I'm sorry. I thought I was going to.
Yeah, just to note that a lot of the evidence as it is out there, it tends to be retrospective. There's not a lot of prospective information on that. So we have a little bit of evidence there. And then, as I had mentioned, you know, we do survey our patients to make sure that we're not causing unintended increases in pain or not addressing that. And, you know, what we have really found is that sometimes it's unveiling another source of that pain that we're able to manage in a different way. So that's just from a clinical perspective, but not evidence per se.
That's a great point. I think the other perspective we've seen in the chat is, although we've introduced it, maybe I'll turn to you with this, Dr. Stewart, introduced it as the importance of shared decision-making is sort of is there an assumption that somebody will taper? Or if somebody is on chronic long-term opioid therapy without any escalation of dose and good functioning, multiple chronic conditions, can that person remain where they are?
Again, you know, it's really important that each patient is looked at individually. And then, so we do have, and even within my own practice, I have some patients who are doing well on their current dose. We have discussed potential of taper and came to the conclusion that this is not the time. So yes, sometimes we have to maintain individuals, but we constantly monitor, make sure that there's no adverse effects, make sure that there's no issues. So again, it's that shared decision-making where the patient and myself, or patient and other physician, we are looking at that patient as they are before us and making that shared decision, whether this is something that we need to do or something that we do not need to do. So there is no one size fit all, and that's really important to make sure that we address that.
Great, thanks, Dr. Stewart. A question for you, Dr. Ogurek. There was a specific set of questions around, it's great to talk about access to these other kinds of therapies like behavioral health, alternative treatments, physical therapy, psychology, and yet access can be so limited. Insurance companies may not pay for it, for example. And I think, you know, given some of you live in some rural communities, I assume access to some of those is hard. Thoughts about, you know, how do we recommend these kind of alternative therapies or options when they're really not available to somebody? And where does virtual care potentially help?
Yeah, thanks, Dr. Burstin. It's a great question, and I wish I could tell you that I had the answers to when the resources aren't available. Sort of, what do you do? It's not an uncommon question that I think, as a family physician, I deal with often, even in an urban area. That when resources are available, but they're not accessible because of cost issues or insurance coverage issues, what do you do? I think bringing to light when national organizations and recommendations are coming out and guidelines are recommending these things, it needs to be a push for the advocacy and the policy for expansion for these things on a larger level. How do you leverage sort of technologies to do these certain things? I think definitely, again, telehealth has opened up capacities where people are exploring ways to do things virtually. I think, there was some of this before COVID. Obviously, it's amplified during COVID because people were forced to figure out how to do this. Do we have the best practices yet? Probably not. But sort of limitations within your direct area maybe no longer are a reason to not have availability to resources, where there may be national sort of bodies or groups that are out there that are doing telehealth, either telepsychiatry or physical therapy opportunities to show people how to do exercises sort of through virtual and video capabilities. Again, there's still barriers around that because there's potentially state law restrictions where some of these things can't cross over state lines and those sorts of things. So these are some of the policy things that definitely need to be figured out as part of this process. And it's such a critical element to this, as we're, again, national attention is being forced on this, and patients oftentimes are put out in the dark and sort of out on their own in terms of these sorts of things. But the policy and the follow through and the access really needs to be there to make sure that people have the access to the things that are being recommended. And we need to find ways to do that.
That's a really good point. And certainly myself as a primary care doc, I mean, being in part of the Council of Medical Specialty Societies, you can see also how we also need to interact with so many other specialists in this space. So I think a really core role of family physician and primary care overall is the ability to interact with anesthesia or interact with physical therapy and others and really help to coordinate that care. A question for you, I'll start with you, Chuck. That is sort of a general comment that's come in that really reflects on unintended consequences, really, of recommendations and guidelines, really on both patients and clinicians. There's an interesting question from a family doc who's been trying to taper patients and is still kind of getting, dinged for the fact that they still have too many patients on high dose meds. Sorry, that's the dog shaking. How do you respond to concerns about unintended consequences, and what can we do to make sure that some of these recommendations are in fact not causing unintended consequences, and how do we monitor for them for both patients and clinicians? I'll talk to you. I'll turn to you first, Chuck, and then maybe then to Liz.
That'll be great, and we'll be glad to have everybody join in. I guess I have the advantage of actually having worked, as part of a contributor to the 2016 CDC guideline as part of their core expert group. And when you look at the editorial, which came out from the authors of the paper, again, just last year, again, talking about the unintended consequences of even the 2016 guideline, how it can be misinterpreted. There's a lot of advocacy work, again, that still is left to be done. So many of us are advocating, again, for the proper way to approach these guidelines and put them in place. I will say that as a provider that continually, again, has charts monitored, I know what you're talking about in terms of, again, someone who's looking over your shoulders. And yes, you document, and you continue to document your reasoning and what you're doing and your logic for what you're trying to do. It's a continual process. There's not an easy solution. And many of the other participants on this call today, again, my co-workers here, again, would also say, again, it's a continual process of advocacy for, again, better understanding, better coverage, and again, patience.
Any other takers, Liz?
Yeah, sure. I can comment on that too. And I think, it's really interesting to hear about the guideline development. And my experience has been that people read that and interpret it overly literally at times. When, there is nuance in the guideline, there's a lot of caveat in there about appropriateness. And so we've had a lot of conversation about, dosing is only one risk factor. There are other things that can increase risk, as it's covered in your paper very well. Things like polypharmacy. You could have somebody on a lower dose and on polypharmacy that has a more compelling reason to taper than, say, someone on a high dose alone. So I think really emphasizing the holistic view as opposed to really laser focusing in on the numbers is a really good way to try to minimize the consequence. So balancing out those goals, because I think, there will still continue to be scrutiny on, trying not to have patients at higher doses if it's not necessary. But there's the flip side of it that can't be ignored, that, that isn't going to be right for every person.
That's great. Thank you. Dr. Stewart, a comment for you. I think there have been a lot of questions about, for example, how would we monitor patients to make sure they're doing okay on a taper and not having unintended pain or other bad effects?
So there's different ways that we can do that. And especially as Dave mentioned, the use of telehealth, reaching out to that particular patient and seeing how they're doing, checking in, doing that check-in, either having that patient come into the office and sitting down and discussing how they're doing, or reaching out via telehealth. So there's different ways in which we can monitor a particular patient to see how well they're doing, whether they're having issues such as withdrawal. And I tend, when I'm tapering a patient, tend to follow them up, in a couple days, and then spreading that out throughout the time. And if they're having issues again, maybe having them come in or maybe having a closer follow-up with them. But it's really important as family physicians, we have those relationships, and it's really important that we reach out, we talk to our patients, we have those follow-ups. It's important. It's really important to have that comfort and where the patients feel comfortable talking with you. Sadly, many of my patients have my cell phone number, or not sadly, but they tend to call me, or I'll check up on them, just, calling them up and, say, hey, Mrs. Jones, how are you doing? I know we discussed the tapering, and how's that going? Seeing how they're doing as far as functioning. And are we achieving what we really wanted to achieve? And if not, then we have to rethink and take a step back. So those are really important aspects that I think are really important to be able to monitor and follow the patients as they go through this process.
Absolutely. David, Liz, Chuck, anything?
I want to echo Dr. Stewart's comments. I think a lot of it too is sort of setting the stage and managing expectations from the beginning. So what are the goals and what are the shared goals? Some of the discussions earlier around the research elements, making sure that our goals are patient-centered goals, and sort of what the patient is kind of expecting out of the experience too, that they sort of feel like they're losing this or they're gaining this or this is staying the same. And those sorts of things up front, and knowing sort of what some of those goals might be or what those expectations might be, are so critical to understanding whether you're on the right path. And I think really the reassurance from the beginning, in circumstances, as was already mentioned, that this is a marathon and a journey. It's not a sprint. And just because you start on the process doesn't mean that you continue on it, or that it's something that needs to continue a certain way or at a certain speed, and not setting up sort of such strict rules from the beginning that you can't potentially go back if things aren't going in the direction or meeting the goals that the patient said, that you and the patient decided on from the beginning. It's just such a core element to that partnership and care, and making individuals feel that they're part of the decision-making process. If we're going to talk about shared decision-making, let's really make it shared decision-making. Let's not make it me just trying to convince you that this is the right thing to do or this is what we're doing, but that both of us have a clear sense of why we're doing this, where we're headed, and what we expect out of the process.
That's a great point. And some people also asked about, for example, are there especially good pain functioning scales or things? I think when patients and clinicians both have a shared set of tools like a patient report outcome, it's easier then, I think, to monitor where you are, see where you're going. And so perhaps I saw some of that was in the AAFP resources as well. Dr. Stewart, specifically a question came up about medical education and how far back do we need to really start teaching medical students? And I would expand this certainly, Liz, to pharmacy students, nursing students. Are we doing a good job teaching pain management, and what could we do better? And where does the AAFP fit in that whole universe of pushing for better education?
So we're working with our other entities, our resident associations, and STFM and all those other organizations to make sure that this is part of the curriculum. We have realized the importance of making sure that our medical students, making sure that our residents are educated regarding chronic pain management and how to achieve the success and how to make sure that they are empathetic with their patients, and making sure that they understand that each patient is different and that there's not one size that fits all. And so our academy is working with other organizations, other AAMC and others to make sure that these are part of the educational process. For us as an organization, we have a number of CME opportunities for our physicians who are out there. We have, as I mentioned, our wonderful toolkits with chronic pain management, and that does have the functional assessment tools. So we have a lot of tools at our fingertips, and we need to make sure that everyone is aware of those tools and how to best use them.
Great. Any other comments on the education front? Okay. I'll just mention the NAM Collaborative, one of our other work groups, and then I'll turn to Chuck, is specifically focused on education and training. And the great thing about that work group is completely multidisciplinary. So I think the goal here really is to come up with a set of education and curriculum that will work across. And as we start thinking more about our work in teams, how important it is that we learn together, have a shared curriculum as well. I interrupted you, Chuck.
No, you took away the point that I was about to make about our work group and everything again. But again, I mean, they're there. I think, again, the other thing that emphasized that Ada was doing, again, medical students and residents need the example of a mentor who does work with our patients regarding chronic pain and tapering and can take that student, that resident through the continuum of the process. Again, emphasizing, again, a patient-centered approach and buying in terms of a risk reduction. So again, our mentors, again, our home can really be key to our students and residents learning the fine art of tapering and pain management.
Yeah, and I'm glad you mentioned residents as well. The ACGME has a set of milestones around pain management, and there's an opioid congress coming up in the spring, specifically to think about the requirements for each specialty as well as overall that ACGME is putting forward. So I think this is going to be a really important question going forward. Let's talk a little bit about populations particularly at risk here. So issues around equity, whether that's related to structural racism or whether that's related to being in a very rural community, or even the stigma of trying to get these care, particularly people thinking you're, perhaps not treating everyone the same as they come in on opioids. Perspectives on that to share? And how we might, particularly in our work going forward, really address the equity issues going forward?
I can talk on behalf of our academy. We are making sure that we address health equity. We have seen that, and we all know those who are on the front lines, how many people of color had previously been treated for pain. They go into a clinic or to the doctor's office and they talk about their pain, and then they've been labeled as pain seeking. There's just so much evidence out there of issues. And so as the academy, we have made sure that we are out there speaking against these particular issues and making sure that as an organization, we are anti-racist, we're addressing health equity at all levels and making sure that each individual is treated the same. And so we're out there advocating for equal treatment, making sure that we put that out on the front lines and just speaking up for our patients who have been for so long underrepresented in all aspects of medicine. So on the national level, we're out there making sure that we speak up and advocate for our patients, and then making sure that we treat and have policies behind the words that we are actually speaking and trying to portray as an organization.
Yeah. David or Liz, anything you want to add?
Yeah, I think Dr. Stewart really tapped into this, and really to truly address it in any meaningful way, it definitely has to happen at a macro level where we're making policy changes to really affect, the way we approach things and making sure that individuals have access to things, and also addressing sort of either a culture or a history of inequity and systemic injustices that have particularly affected communities. But I think it's prudent for all of us as we engage sort of through this process that we're just very mindful. And I alluded to this when I was talking, in the language we use, and not perpetuating stigma, marginalization, and trauma in our own processes as we're trying to do this. Sort of the forced sort of, physician-centric or system-centric approach that sometimes comes about with this perpetuates trauma, perpetuates stigma. So just being mindful of that. So as we're thinking about this and approaching us, all of us sort of have due diligence to check our implicit and explicit biases and be aware that, none of us will be able to get rid of those implicit biases, but going through trainings and understanding some of the challenges about that can potentially make a difference as we forge forward.
That's great. Liz, I want to give you a chance as well, since obviously pharmacists, when we did our listening sessions, are very much at the front line of a lot of these discussions with patients. Perspectives on the equity issue?
Yes, definitely. And I agree with what's been said. Another thing I thought about in this category is generally that as you're tapering off an opioid, there may be times where you realize that maybe there were unrecognized or unaddressed mental health issues. And so making sure that that's also considered and supported either through a referral or as part of an interdisciplinary team, because, it's really important that we're not just taking away that medication support and, not addressing that other underlying issue. And I think that's something that's tied into the whole discussion around equity.
Great, such an important point. We've got just a few minutes left. I want to do one last round robin across all of you and ask you, what's one particular aspect of this that you think, one particular best practice you think is really important takeaway for people who've been listening in today, to take away from this really just remarkable discussion, which, by the way, many people have asked. You will be able to access it on the NAM website. So, you get a chance to listen in more detail. Start with each of you in the order in which you presented. So Chuck, I'll start with you. What's your one takeaway you want to have people make sure they think about?
My takeaway again for our providers and patients again is listen to our patient, listen to what their pain drivers are, listening to their daily life and how the pain affects them. And then make sure again that you tailor the plan, tapering and others to make sure again you're addressing those patient needs again. Tapering without meeting the patient's need where they're at is going to fail. You must address the patient and meet them where they're at.
Perfect. Dr. Stewart, I think you may have a similar theme, but let's go for it.
Yes, pretty much piggybacking on what Dr. Rich said, this is a shared decision making. But I do want to mention that the AFP has resources for you to be able to help you to help your patient get through this. This is a shared decision making, and we have to make sure that we meet our patients where they are and that there's no one size fits all So I guess that's kind of two points or three in there, but those are really important. And again, our AAFP has the resources that you need to be able to help your patient get through this.
Wonderful. Liz, how about you?
Yeah, and just to pull something out we haven't really talked much about, just think about naloxone when we're tapering and when we're prescribing opioids for our patients. I think of it as like a rescue inhaler for someone with asthma, you know, just it's not something that we're giving you because, you know, we think that you're going to have an overdose necessarily. It's just there for safety in case you need it. So wanted to put in a plug for naloxone.
Perfect. David, last word.
So I think as we think about the behavioral health elements and integration components, I think recognize that the trust and connection for our physicians and providers that you've potentially connected with your patients puts you and should empower you to be that first frontline level of person who could start the process for that behavioral health integration. And you are equipped with tools where you're perhaps in the best position to deliver some of that behavioral health care. So trust your instincts and your skills and certainly put them into play.
Great. Well, thank you all. And thanks to National Academy of Medicine. Thank you to AAFP for just a remarkable discussion today. I'm sure lots of folks will want to go back and rewatch this, capture some of the pearls as part of this discussion, and given us, we couldn't get to all the questions. There were so many. I hope I at least tried to pull out some of the key themes in the Q&A box, but you've given us lots of food for thought, I will tell you, as we go back and think about the next phase of our collaborative. Some of those questions you've raised, particularly about the outcomes basis, I think is going to be something front and center that we'll talk about with our research and metrics team for sure. So thank you again. And perhaps if you just go to the last slide, everybody could see, just to remind you where you can, we did that, next one. You can find NAM online there, and the video will be posted on the NAM website. And thank you all for joining us today. Best wishes to everyone for a very safe and happy holiday season. Thanks again to our panelists, and thanks to AAFP and NAM. Thanks again. Bye-bye.